All right, so we are continuing with the second part of the guidelines updates, and I would like us to look at why DTG is such an important drug and why we believe that it is probably the best drug to replace the weak NNRTIs. So let's then go into it. All right. So the first thing you see is that in terms of risks and benefits, right, dolutegravir probably has more benefits than your efavirenz-based regimen. And this is because it is a potent drug. We will be able to get patients to be suppressed quicker. It is generally well tolerated, improved adherence because it does not have these neuropsychiatric side effects that you would get with an efavirenz-based regimen. It has a high barrier to resistance. That means even 1 or 2 mutations would not make, dolutegravir less effective. It takes time. It is very difficult for a virus to develop resistance to dolutegravir versus efavirenz, which has a low genetic barrier to resistance, usually just 1 mutation, K103N, it would make the whole class really to be non-effective. There are no drug-drug interactions with hormonal contraceptives. This is something that we struggled with for years. So we always encouraged our patients to say, if you're on contraception, also use condoms because there's significant drug-drug interactions with efavirenz, nevirapine, including your TB treatments, and so on. So some of the risk really in today's world, it's a very low risk of neural tube defects. I must say, as I'm going to show shortly, this risk really is neither here nor there. It is so low that the benefits would outweigh, any risk that we can think of. Whenever you give dolutegravir, you need to consider significant drug-drug interactions, especially with drugs like your anticonvulsants, some of the vitamins that we use, your iron supplements, the aluminiums of this world, your TB treatment, particularly rifampicin. Those are very important. There is a risk of weight gain. However, most ARV drugs at some point they contribute to weight gain. However, there's a lot of reports around significant weight gain with dolutegravir. But all in all, the benefits really outweigh the risks, and it's a drug that we really want to recommend at this point. So dolutegravir, in summary, it is a potent drug, and in a regimen, it offers superior efficacy and a faster rate of viral suppression. It is well tolerated. It has a high barrier to resistance, and there are no known, there are no known drug interactions with family planning or hormonal contraceptions. Like I said, you must pay attention to drug-drug interactions. And, at this point in time, we believe that they are very comparable. Both DTG and efavirenz are very comparable in terms of neural tube defects, and the difference between the two really is statistically non-significant, as I will show very shortly. All right. So in May of 2018, a safety signal was raised, and at that time, the studies at that time had showed that DTG had quite a higher incidence of neural tube defects versus efavirenz. In the 2019 conference, more data was released, and you can see that the risk now is actually quite very, comparable or low, And if you look at now as a drug which we use now broadly in the world, there's only 7 cases that have been recorded, and this was also in patients who were not on folate. So one gets a sense that if they were given folate, this couldn't have happened, and probably the cause is not a pure DTG, related outcome. The same study, which had reported a higher incidence of neural tube defects with DTG, the Botswana Tsepamo study, has recently found no significant differences between dolutegravir and efavirenz, basically telling us that the big concern and the noise we used to make to say, be cautious, you know, we need to change now and probably consider giving DTG to all patient populations, irrespective of whether they are pregnant or not, and within pregnancy, irrespective of whether this is during the first, second, or third trimester. Issues of informing women about the risks should be done with every drug, whether DTG, efavirenz, fluconazole, all drugs that are known to be teratogenic. The counseling should always happen, and we should always integrate family planning and discuss fertility plans, you know, with women, irrespective of which drug is used. But the change, there must be a change in our messaging to say DTG and efavirenz, a choice can no longer be reduced to issues of conception, right? DTG is now a superior drug, you know, in terms of potency, in terms of drug-drug interactions, issues around side effects. So it's a drug that we really recommend. And we also don't want patients to be taking a weak first-line regimen with the risk of treatment failure in the long run. So these drugs are comparable. The risk is very low, and we should be now encouraging the use of dolutegravir for all HIV-positive patients. Following those publications, the World Health Organization also has now made recommendations to say DTG containing regimens are now recommended as a preferred first-line ART regimen in all patient populations, including women of childbearing potential, right? So if you see a woman tomorrow, whether she's on family planning or not, the first drug to recommend is DTG. If she's in the first trimester, the first drug to recommend is DTG, because we follow science, and science tells us that the drug is now a safer option, right? So South Africa now, the EML committee, the National Essential Medicine List Committee, has now reviewed the evidence and compared dolutegravir with efavirenz, and has concluded that the benefits of prescribing DTG for all patients, whether pregnant or not, in all trimesters of pregnancy, whether on family planning or not, outweigh any risks that we can think of. Ours is to now re-educate our patients and inform them that actually the drug is actually safer, and it's a better option for you in terms of the viral load control, but also the durability, how long you would stay suppressed after you are initiated on DTG, the side effect profile, and by God's grace, it is also available as a single tab, one tablet once daily. So dolutegravir in South Africa is therefore recommended as part of the preferred first-line ART regimen for adults and adolescents living with HIV, including pregnant women and women of childbearing potential. So that is very important. So when you prescribe it, you can prescribe it to children, adolescents, and adults as long as the weight is above 20 kgs. So the standard dose is dolutegravir 50 milligrams daily for every patient or client whose weight is above 20 kgs. In the context of TB, it needs to be prescribed as dolutegravir 50 milligrams 12 hourly, right? So if they're taking TLD, tenofovir, lamivudine, dolutegravir combination, let's say a patient is taking that every morning, so they'll continue to take TLD in the morning, and then in the evening you prescribe the single DTG tablet, the 50 milligrams, to take it at night. That would make it 12 hourly, right? So it's available as a 50 milligram tablet, right? Note that TLD has 3 drugs: tenofovir, lamivudine, and dolutegravir. For dolutegravir, you need a weight above 20 kgs. For tenofovir, you need a weight above 35 kgs. So you cannot prescribe the single tab once daily combination for patients who have a weight below 35 kgs. So we need to pay attention to that, or those with an age less than 10 years. So if someone is over 10 years and the weight is above 35 kgs, you can give them the single tab once daily, once they get to that particular age, right? So also note the different brand names that are out there, pharmaceutical companies. These are determined by government tenders, in the private sector. These might be options, especially for patients who want to pay for cash, because they tend to be cheap if you go for these brands, But for your own learning, you need to know the active drugs that are being used. You can see on this one, it's McLeod's, but you can see there's dolutegravir, lamivudine, and tenofovir. Because sometimes a patient will come to you and say, hey, I'm taking McLeod's. You'll struggle really to know what is McLeod's and what drugs. But if she brings the box, you look at the active drugs that are being used. You would then know what drugs are being used for this particular patient. All right.
To meet the
Now, obviously, with all good things, there's always some things that you need to pay attention to. So adverse events are there. So firstly, they are not. And this is very important. Number one, these adverse events are not common. These are rare side effects. And when they do happen, they tend to be mild, self-limiting, where you probably need to treat your patients, symptomatically. If a patient does not cope with sleep disturbances and they're struggling to maintain sleep, you might ask them to take their TLD in the morning. Usually by just changing the timing, they do well. Nausea, diarrhea, headaches, these are things that you are likely to manage symptomatically, and they tend to happen very early on and they improve over time. And we need to encourage our patients to not stop ARVs without discussing with us. That is quite important. Weight gain over the long term. So patients who have taken dolutegravir for over a year or more might start to complain of weight gain. Remember, weight gain, even if it happens very early on, most people who are sick, they are happy to gain weight very early on. But if it continues, it becomes a problem. So we need to start lifestyle interventions, lifestyle modification, exercise, adjusting the diet, and even counseling by your nutritionists and dietitians is quite useful for these patients. So it's something that we need to pay attention to. I also need to say that if you start a patient on a dolutegravir-based regimen, their serum creatinine levels may increase, but it is usually by less than 15%. So if you think of it, if someone had a creatinine of, let's say, 80, it might increase by about 8 to 10, millimoles and so on. So it is not something that is clinically significant. You need to pay attention to it. However, if this creatinine level continues to increase and increase, and it's increasing, probably more than 15%, that is not a DTG type of increase. You then need to review the use of tenofovir, other nephrotoxic drugs. Check if your patient has other chronic conditions, diabetes, hypertension that are not controlled, or any other secondary causes of renal disease, right? So here we usually do not stop or even switch DTG. If you need to review, you probably need to review the use of other drugs that are being used at that point in time. In terms of drug-drug interaction, TB treatment is quite important. So rifampicin is a liver enzyme inducer. So generally dropping the blood levels of dolutegravir. So in the context of TB, you would want to increase the DTG dose to 12 hourly. So the TLD dose being taken, let's say in the morning, and then at night, they take the additional 50 milligrams of DTG to counter the effect of rifampicin on the drug. Then there's the anticonvulsants, especially your first generation phenytoin, carbamazepine, and so on. So there you need to be careful. Firstly, where possible, you want to avoid co-administration. Otherwise, you may want to use your second generation anticonvulsants, and where maybe Tegretol is taken and really you don't have a choice to make any switching, you might need to increase your dolutegravir dose to 50 milligrams 12 hourly to counter the effect of your liver-inducing anticonvulsants. In terms of metformin and DTG, this is now the opposite, where DTG increases the blood levels of metformin, right? So it is not recommended to prescribe DTG to patients who are taking more than 500 milligrams 12 hourly of metformin. In other words, if anyone is taking more than 1,000 milligrams in 24 hours of metformin, it's probably best to consider other ART regimens in that case. Otherwise, they would reach toxic levels of metformin, which will cause serious problems, right? Other drug interactions are with your cations, your magnesiums, aluminiums, your antacids, other nutritional supplements that like your iron supplements, calcium. So very important that you pay attention to these and you ensure that you either deal with them in terms of timing, you know, or even taking those supplements with food. So that is quite important. So we also want to make sure that yes, DTG is safe in pregnancy, but the issues of integrating sexual reproductive health services as part of HIV care and other types of cares is very important. So we don't want to now stop, to have these discussions with women. It's very important that whenever a woman is started on ARVs, that the discussion about, their pregnancy plans and fertility intentions, that it is done, that you discuss, the benefits and the risks of all drugs, not just DTG and efavirenz, and then make sure that women and our patients are involved in those decisions. We might be having patients currently on efavirenz who prefer to stay on efavirenz, and we should not fight with them. We should actually support them as needed, right? And then family planning is very important. In the HIV context, we prefer planned pregnancies because we want women to fall pregnant when their viral load is suppressed, their CD4 count is going up, and they do not have any opportunistic infections at that point in time. So that is very important. So in terms of just summarizing first-line regimens, now you would see that we are not talking about efavirenz, right? The only thing is the use of nevirapine for babies less than 1 month. And here is because we know that we cannot use lopinavir at this at this age because it makes our kids a bit sick. So we will use nevirapine with AZT and lamivudine. This is a transition regimen. As soon as the child is more than 4 weeks old or the weight is more than 3 kg, we would need to transition them to the standard first-line regimen for children who have a weight less than 20 kgs, and that would be abacavir, lamivudine with lopinavir, ritonavir. So this is very important. And also note, during this particular transition from this regimen to this one, you don't need to check the viral load. The transition must just happen, right? However, any other transition, we would require a viral load, evidence of a viral load that is suppressed, all right? So if you have a child who's more than 20 kgs and they've tested positive and they are being initiated for the first time on ARVs, a combination of abacavir, lamivudine, and dolutegravir would be a best combination. And then later on, if they do grow up to be more than 10 years and their weight is above 35, then you can use the adult TLD regimen, which has tenofovir, lamivudine, and dolutegravir, right? So that is quite important. So whenever you are initiating a patient, come back to this table and say, how old is my patient? What is their weight? If you are dealing with a 10-year-old who weighs, I don't know, 15 kgs, for argument's sake, well, 15 is between 3 and 20, so they'll be here, and that is the regimen there, right? If you see a child who tests positive during birthing. So you did a birth PCR that is positive, and it's positive. Then the child needs zidovudine, lamivudine, and nevirapine. You've got a child who weighs 25 kgs, less than 10 years, abacavir, lamivudine, and dolutegravir. As soon as the weight is above 35 and the age is more than 10 years, you can give the 1 tab daily adult combination regimen. So that is very, very important. So in summary, dolutegravir is an important drug. It has a high barrier to resistance. It's well tolerated and it's quite potent. There are side effects we need to know about. Like I said, they are not common, and half the time they are mild and self-limiting. Whenever you prescribe dolutegravir, pay attention to drug-drug interactions. And then lastly, the issue and the risk of neural tube defects, is fading. So we have to make sure that we still empower women to make an informed decision and work very hard to integrate family planning services with HIV care services. All right. So yeah. So I'm going to stop there, and I hope that you have managed, to grasp the core of this message, and that you would apply these guidelines, in your clinical practice. For any questions, again, send us an email, to support@aquatraining.com, and then we would be happy to help as needed. Thank you.